Hello everybody again, and welcome to this lecture. The lecture will be the attrition, so it's a kind of worn dentition that is happened to find in many patients over years, and is very classic to be then rehabilitated with extensive rehabilitation of one or two arches. So we try to follow a kind of predictable approach, clinical approach, step-by-step procedure. Okay, so let me show you the first two pictures that's showing a kind of wear facet. It means that is match up with the upper and lower arch, and actually that is also happen in the work that you do yourself. Maybe you have delivered a case 12 years ago, and that's the result after 12 years, that they are still grinding, and fortunately not having any kind of cross-section fracture. But that is the sign that something works so heavily. So attrition can be divided in physiological one and in pathological one. So normally the occlusal contact area means that you miss about 29 microns per year for molars and about 15 microns per year for premolars, for bicuspids. So that is a physiological one. It means that anyway you can lose some enamel, some tooth structure for sure. This is unavoidable. The total duration of the masticatory cycle was reported to be approximately 0.70 seconds, while the mean duration of the occlusion when the teeth touch each other is about 0.10 seconds. And the total amount the teeth are in contact each other is between 15 to 30 minutes. That is what is a normal physiological wear. So when you talk about pathological attrition, at this point we have to consider different kind of potential etiology, like the chewing pattern, the envelope of function, the malocclusion, and of course the braxing activities, such parafunctional activity. So where, both due to the attrition is equally common in maxillary and mandibular teeth. And again, you can see the match-up upper and lower. And if you have a normal occlusion, so-called normal occlusion, with a cuspid and the incisor that overcome the lower arch, so I'm talking the cuspid and the upper incisor, and overcome the lower arches, you have the chance to see that you see maybe some kind of attrition on the cuspids and on central incisor, lateral incisors. And that is mostly so on anterior teeth. But at the same time, when you continue to grind, when you cut away all these cuspid and incisor, you start to see the same kind of problem also on posteriors, but just later, of course, later. So pathological wear, and talking about braxillum activity. That is very interesting because, of course, braxillum activity is one of the destroying area of our work. That is really something that we don't like to have it. So what about the epidemiology of this braxillum activity or braxillars? First of all, there is no difference in sex. Men, women, both they have it, no problem. And there is a great variability from 6% to 91%, so depending on the case, but normally is not constant over time, this kind of braxillum activity. And what is interesting, that just 1/4, so 23% of the people understand that they are braxing during the night. They can feel it. But most of the time, is the relative are the people that sleep together, and they can say, oh, you brax a lot during the night. But normally it's not so visible, so understandable by the patient himself. So the braxing that is present at an early age will continue into the adulthood. But at the same time, the subject over 60 years old getting lower. So there is a significant reduction in episodes. So that's interesting too. So what about symptoms and sign? We can have symptoms as a sign in a questionnaire. We have some signs like the tooth wear, of course, the fracture. Sometimes you have so heavy braxillary that you fracture the vital teeth. And then you have tooth mobility, sometimes the big trauma, primary trauma. Pulp necrosis, because you cut so much the teeth that are completely going to the pulp. Then you have also traumatic ulcerus, masticatory muscle hypertrophy, like the picture that you see in front of you, and to the interesting differentiation, that is the linea alba, a kind of white line inside the cheeks, very, very thin one, going around at the same level of the occlusion, and the tongue indentation. It means a kind of impression of the lateral part of the tongue of the teeth itself. So they are grinding, that probably pressing the tongue and having the chance to create this kind of impression of the tongue. That is a really, really particular one, is a specific one. So today we can study brachial activity through very important elements, through very important devices. So today we have the chance to do the polysomnography. Polysomnography is conducted in a sleep laboratory. It's maybe the most accurate method for studying brachial. And as is written here, it records biological signals such as electromyography, electroencephalogram, electrooculogram, and electrocardiogram, as well as audio and video signals. So it's also complemented by monitoring of the subject by means of infrared video camera focused on the head and neck. And the microphone is also placed over the head. Seems to be almost impossible to sleep during the night with all these steps. But anyway, seems to be the most complete and modern way to understand how the brachial activity is. It's also interesting because today we can also have a kind of relationship between sleep apnea, that many times is obstructive sleep apnea, and you find that we have used this kind of appliance for during the night to control the brachial activity. You have the chance to have this kind of open this space over there, as you can see on this picture here, and reduce the brachial events by 50 to 83%. So the position of the mandibular advancement appliance, because it's a special bite, not the classic bite, is an appliance that is putting the mandible more in front, is an advancement appliance, can achieve a better space for your tongue, and you have the chance to have reducing the brachial activity by 50 to 83%. That is very, very important. So improving airway patency is an important strategy for brachial. That could be possible. So just to repeat where you can find the wear, anterior more than posterior in two cases. One, when you have a wear facet match-up with the brachial activity. It means that you have the edge to edge that are, really matching up both of them. And that is the brachial activity. Then you have a situation in which you have a smooth lingual wear on the upper anterior, that becoming from the molar and then to the bicuspid. That is very classic of regurgitation. Upper, but also sometimes also the lower. So then you have the wear that is more posteriorly than anteriorly, and normally has a capping, a cratering, volcano-shaped lesion. It's very classic for soda swishing, fruit mulling that are turning out in the mouth or before swelling. They will put in the mouth. Talking about the young generation normally. And that creates even posterior wear, upper and lower, or lower first molar is the most severe normally with the fruit mulling. That is something that is very interesting that happens. So more posterior than anterior. Let me go through the brachial activity and occlusion, because many people, at least in the past, were talking about this kind of potential problem. So if you have no good occlusion, you could have the chance to start the brachial activity. Is it true? Is it fake? Let me check with you. Ramfjord was the first one to do some study on monkeys. And actually, in this case, we have put the discrepancy between the retruded contact position and the intercuspal position. And also have some balance inside with some interferences. And the occlusal adjustment, with the grinding procedure, of course, in this case, always led to a disappearance of brachial. So these monkeys, as I said, stopped the brachial activity when they completed the elimination of the overfilled part of the restoration in the first molar. So according to this study, very classic study, seems to be actually that if you remove this kind of interferences on posterior area, you can also stop the Braxton activity. In contrast with Ramiford, we have the study from John Rook, in which they put artificial occlusal interferences incorporated in crown in the molar region on the masticatory muscle activity. And in contrast with Ramifjord, these kind of interferences cause a significant decrease in the sleep-related muscular activity. So in 90% of the cases that happens. So really in contrast, completely in contrast with that. So who is right, who is wrong? That is complicated to say. And what to do in a case like this, that is an incredible, extreme wear case. What to do? So what is the etiology? Maybe it is multifactorial etiology. Can be related to the occlusion? Maybe. Can be related to the stress? Or can be related to the central nervous system that is regulated by the central nervous system. So let me show you. Of course, if you take a look about the old studies from Ramifjord to the last speaker that you see here on the left side, they say the establishment of a perfect occlusion reduces significantly the temporal mandibular disorder symptoms and the sleep Braxton activity. But at the same time, the National Institute of Health, American Health, and the American Academy of Orofacial Pain say that evidence does not support occlusal adjustment as a reasonable therapy. Yes, I can understand. But at the same time, I would say that is valid if you have the entire mouth, normal mouth, just to do occlusal adjustment. But if you have to do a new kind of work, a new kind of rehabilitation, you have to invent a new occlusion. And of course, you can put all the normal determinant of occlusion inside your rehabilitation. That is our advice anyway. So what about long-term data? Difficult to say. Again, Peter Dawson said, in the majority of patients, it has been my clinical experience. Signs and symptoms of eccentric Braxton activity disappear completely with elimination of the interferences. So again, it's not really a research, it's not really a clinical study. It's not a science study. It's just a clinical approach, because it's saying is my clinical experience. So it's not possible to say that is true 100% maybe, because it's just the experience of a guy, of a dentist. So now, let me tell you what Gilles Lavigne, one of the most experts in this field, is explaining now to us. This is an article that published more than 10 years ago, but still very, very popular. We divided, as we know already, the Braxton activity in two ways: awake Braxton and sleep Braxton. In terms of awake Braxton, we know that the major reason why we have this is the stress. So it defined as the awareness of jaw clenching associated with the reaction to stress, reported to be 20% among the adult population. So you see in front of you a friend or a guy that you don't know maybe talking to you or listening to you that is pumping the masseter. You can see that is clenching. That is maybe, probably, as Lavigne said, related to stress. On the other side, when you talk about the sleep Braxton, seems to be a kind of sleep disorder regulated by the system, central nervous system, that can regulate all this stuff. And it seems to be a kind of, as I said, sleep disorder with a kind of microarousals, respiratory cardiac rhythms that goes up 10 to 14 times per hour. And then you brax. So let me read with you. It's a behavior that was recently classified as a sleep-related movement disorder, secondary to sleep-related microarousals, defined by a rise in autonomic cardiac respiratory activity that tends to be repeated 8-14 times per hour. So there is just a limited evidence to support the role of occlusion in its etiology. So again, if you are a prosthodontist or you are a normal dentist, a GP, a general practitioner, we should have the chance to say, oh, I can find a way maybe to fix the problem if the occlusion plays a role. But if it doesn't play a role, what to do? It's very complicated for us because you have not many, possibility to do differently. We just do the dentistry. So what to do in this case? Would you like to do any prosthetic treatment? Or would you better say, I want to take the chance to see what happened? This is the same appliance that we can put in any case also to protect the dentition, but at the same time to relax the muscles. You can use also occlusal splint that is extended to the molars, also a kind of deprogrammer just put anteriorly. That is the way to react to decrease the intensity of the muscle activity even more. But because we wanted also to protect the TMJ, we want to contact on posteriors. Anyway, what is the meaning of occlusal splints? First of all, decrease the noise of grinding. So the wife of this guy was very happy for that. Secondly, is a kind of protecting teeth restoration, even though unfortunately in this upper teeth you cannot protect anything more. And you can test a new occlusion and video. If you have to increase the video, as should be very normal, at this point you know that at this point you can do it because you can try before with appliance and you have increased the video a certain amount, you can do the same amount with the final work. So you can test it with this kind of appliance. But then you have to decide, and if you accept to decide to treat the patient, at this point in case of treatment, you should understand who you are. Are you a dentist? Are you a psychologist? Are you a neurologist? Are you doing a different kind of work? Because anyway, at the end, you can visit many other specialists, but you will be the guy that will treat him prosthetically, asking a lot of money and taking a lot of risks at the same time. So, I would like to first of all verify the discrepancy between maximum anticipation position and CR, because I would like to put my patient, of course, in this case, in CR position. And then I would like to evaluate the video. Is it lost? I need to increase it. How much I have to increase it? What happens when I increase it? How to test it? All questions that we have done also in other lecture. And then I want to verify the TMJ with the load test. I want to overload the TMJ through the anterior, like cotton roll or Lucia jig or leaf gauge, and the loading and the chewing, having the chance to see, not being protected by posterior teeth, because you have exclude the posterior teeth through the anterior deprogrammer, for example, or the anterior bite. At this point, you have to see what happened on the TMJ. Is increasing the tenderness or decreasing? If it's decreasing, because it's a muscular problem in that area. If increasing, because maybe a TMJ problem. So it's a kind of test. It's called the load test. And then you have to identify the wear etiology. Wear etiology, what is the wear etiology in this case? Is like brushing activity, is part of also erosion. The goals are the same anyway. The main goals are recreating occlusal stability in center relation position and recreating anterior guidance to disclude the posterior teeth during excursive movements through the right ratio between overjet and overbite. So now, tiny bit about treatment planning in this case. It's not easy to decide what to do. Even though in the lower arch is easy, you can maybe build up all the restorations on this area that are all or not dentition. We try to save this tooth here. We go from first molar, putting implants here, to the first molar that area. On the upper jaw, very short teeth, invisible teeth, plus two teeth, molar in between two areas, a bicuspid also between two areas. So what to do? You can have a different solution maybe. You can remove the two teeth on the back and do implants with the sinus elevation, both sides. You can keep these teeth, but to keep it, you have to do something before. You can maybe connect this teeth with this one on fixed pros. So you can have different options. Also, you can extract all teeth to do all implants. It's up to you. At the same time, what you say is, to save these teeth, we need to do something because we have no ferrule effect. As you know, we should have around 2.5 millimeter axially in order to have the chance to keep these teeth in place. So we need to do some crown lengthening procedure, surgical crown lengthening procedure. At this point, you have to ask yourself, what about the root form? Root form on anteriors. They seem to be quite conical. What about root length? Seem to be quite short. So what about the possible mobility after a surgical procedure? Tooth mobility. And I could say, maybe it could be possible. So it will be not easy decision. Each road goes to the same place, but anyway, you can select the one that you wanted to achieve. And mainly, we have the chance to have some problem on these two teeth that are really in the middle of the road. So, at this point, we decided, in a questionable way, of course, after having saved many little roots in my life with the many periodontists, in this case, we extract all teeth and positioned these implants at the same day of the extraction. So it was an immediate loading. And the last molar on the back were tilted to the anterior area in order to avoid any kind of sinus elevation. We have extracted all the teeth at the same time. So the lower arch, we have prepared the teeth to receive the restorations. We have one implant in this area here, first molar on the lower arch. That was the lower arch before preparation and finalization. All ceramic restoration in place. And then video. We have discussed in another lecture about video. We know that we can increase the video and we can achieve the space that you needed for your restorative material. You can, at this point, increase the video, optimize the functionality of these teeth. Why? Because you can recreate the better axis, long axis, and the best overjet overbite ratio. And together with aesthetic improvement, you can rectify also the anterior teeth relationship with a new overjet overbite ratio, as I said, and creating new kind of physiological occlusion. At the same time, increasing the video, you can reduce the need, or better to say, avoid the need to do any surgical crown lengthening procedure. Avoid the need to do any kind of endodontic therapy. I want to keep all the teeth vital if I could. So let me understand. What about this video here? Vertical dimension of occlusion. Have you lost the video? Of course, yes. Everybody can say that. At the same time, you have to understand that you have always some doubts. Why? Because until the teeth are still clenching together and grind together, so they are in contrast one each other, okay? In contact each other. At this point, you could understand that sometimes, many times, you have a mechanism of compensatory phenomena that create new bone apposition from the cementum of the root, creating a kind of over-eruption of this area. So at the same time that you have the teeth are, shortening, at the same time the bone is growing, maintaining the same height than before, original height. Why? Because you are guided by the contraction muscle length that decide that guide that. So increasing the video is impossible to avoid it. You have to increase the video, but that doesn't mean that it's lost. Video is not lost automatically. In this case, most probably will be lost. But anyway, at this point, I have to say, probably is lost, partially at least. But we don't know how much. We don't know exactly how much. Or maybe not lost at all. Because if the eruption occurs at the same rate as tooth rate, the video remains unchanged. If not, the video may decrease over time. And as already shown to you in another lecture, that's what happened. You see the teeth are shortening. You see here, from this normal length to this. But then the bone level here, A, is increasing. So you have a compensatory phenomenon. Could be. And again, as already shown by this article by Abduo, whenever indicated, increase of video up to 5 mm anteriorly is safe and predictable procedure, with a tendency to resolve within a couple of weeks in terms of symptom and sign, just in case you have this kind of associated sign and symptoms. They were self-limiting, with a tendency to resolve within a couple of weeks. Let me show so this case. It was an old movie that when he did long time ago this case, and you see that we guide the mandible. It was reverse occlusion. It appeared to be reverse, but it's not really completely reverse. If you then close, of course, they go on the reverse occlusion. But if you guide the patient in CR, it's touching now. Touching. It's not going in front as before. So it's sliding down in front. So maybe you can improve 1.5 millimeter of slide, anteroposterior slide. And that's the reason why, together with the increase of video, we have the chance to optimize the case. Look at this. That's the initial situation. And that's the final outcome. Seems to be impossible to find this kind of final result if you look at the first picture on the left. But combine the two factors. Remind me. Once was the increase of video of a few millimeters, increase the overjet. Overjet value is increased by the increase of video. If you increase 5 millimeters the video, you increase almost 2 millimeters of overjet. So that's helping you to achieve the normal relationship. Plus, you guide your restoration, your mandible to the CR position. As you have seen, at this point, you have the chance to see that you can retrude this position of the mandible, not because the CR is the most retruded position, as you have seen in the past, is the most anterior-superior position, as you know, but because the mandible lost their own position, original position, and they go forward. So now you are putting back to the original position, anterior-superior position. So you go back 1 millimeter maybe, you increase the video, added 2 millimeter overjet is achieved by that, and altogether you can achieve this kind of result on the right side. That is quite remarkable, I believe. So we have used the reorganization approach with CR positioning. Of course, when you talk about wear, you have to remember also the envelope of function that is most of the time constricted. Like in the bruxism activity, what we need to do is to try to widen the anterior guidance to create some space for the mouth of the patient. In many cases, you can keep this into control. So it means that you can control this problem. But in some cases, they continue to grind in the same manner that they did before. So 75% of cases, it works well if you consider that you create a new kind of pattern, but in some cases not. You have to consider that. Anyway, the final outcome is the same. You should restore your teeth having decreased the vertical overlap, increasing the horizontal overlap. So having less overbite and more overjet. That is what we believe that is important to achieve. Because remember, for every 10 degrees change in the angle of exclusion, there is a 35% change in force applied. And we want to decrease as much as we could the force applied on teeth to avoid any kind of fracture or chipping. So if with the 10 degrees of change being flatter, so because the flatter the angle, the lower the muscle activity is, you can save, mainly can save the restoration that you put in place. So that is very important rule to remember. That is the final outcome of the case that we've done. You see now the two last implants that are tilted in front to avoid any kind of sinus elevation. That's allow us to do everything in one day. Remove the teeth, put in the implant, and put the provision in place. There was an immediate loading. So the increasing video that we made cannot create any big problem at all, can have at most a transient patient discomfort, no muscle pain, and no joint pain. That is something that was visible by many authors, as you've seen now. In some patients, anyway, the alteration of the video will be vanified within approximately 6 months, going back to the original position, without causing any discomfort or pain to the patient, and without seeing anything by yourself. You cannot see anything. That is a potential situation that could happen, but we don't see. They move it. So you have increased video, and we have really increased video because you have a compensation phenomena before. So when you have a grinded teeth, you have a short teeth, seem to be lost the video, but was not lost. I understand what they said before already. Now you increase to find the space. So we increase really at this point the video over the normal value. So the muscle length, the contraction, clenching, create a kind of recollapse down of the two arches, creating the same level than was before. This process is really difficult to be seen. It's not possible to be seen, I could say. Some authors wait 6 months before finalizing the case because they want to wait for that. Frankly speaking, I don't do it normally. I don't see any difference, remarkable difference, at least before and after. So anyway, even though that happened, in any case, the clinician will be able to benefit from the clinical advantage obtained with alteration video decided at the beginning of the prosthetic treatment. So we don't know what happened inside, but what we know that we increase the video, we open the space, and we use that for our rehabilitation. And then all the mechanism can exist partially, totally, we don't know exactly how much, but still we don't care too much if, clinically speaking, it doesn't create any problem. Before and after, but what to say? If you have an extrusion in this case, because there is an over-eruption of the two arches, because you have a short teeth, so you can have the compensatory phenomena creating more bone underneath. But at this point, after the extrusion, you can have an intrusion, as you have seen. But not in this case, of course, because you remember this guy has implants on the upper arch. So it couldn't happen in this case, on the upper arch. It can happen just in the lower. There is an interesting article by Ormanier showing that in this case, we have the possibility to have three different kind of solutions. Implant versus implants, teeth versus teeth, and teeth versus implants. So let me show you. All patients successfully adapted to the new video. 2 patients in group B, implant versus teeth, and 4 in group C, implants versus implants, reported tooth clenching and grinding, which disappeared within a couple of weeks. What that means? In the implants, with implants, you cannot have a rebound to the original position. You cannot have any kind of re-intrusion. So they fight to find a way to be not involved on this process, and actually the muscles are hyper-contracted, and they need time to release. They need time to decrease their intensity. As you could see, implant versus implant is the worst condition, of course, because there are 2 arches, they both are not possible to be intruded. Less problem was group B, implants versus teeth, like in our case. And no problem was on teeth and teeth in the upper, teeth in the lower. So teeth in the upper and the lower is better kind of reaction because they are both arches can be partially or totally reintruded. But with the implants, if it is one arch implant and one arch teeth, just the teeth area can be intruded, but not the upper on the arch, on the implants. when you have implant against implant, you cannot have any intrusion. So you have to wait in a complete adaptation by the muscle. You need at least a couple of months. For that reason, when you have to do a kind of big rehabilitation implants, I will wait for at least a couple of months or 3 months before finalizing the case. So I will wait until the grinding procedure on provisional will be stopped. 10 years later, I believe that it's very nice result being 10 years later. The goals were achieved. We have optimized the function. We have improved the muscle comfort because you have to exclude the posterior teeth during exclusive movements. You have no interferences. We also dissipate the muscle, the load, because we have at this point involved the 4 lower anteriors in the disclusion. You see the 2 upper central incisors are in contact with the 4 lower anteriors, the 4 incisors, and that is distributing in the better way the load every way. So having the improved muscle comfort. Minimize the load in TMJ because the extension of the occlusion up to the molars helps you when you clench, when you bite, okay, when you're chewing, you have the chance to have contact on posteriors, so the load goes mainly to the teeth. If you have marked contact, well distributed, and we synchronize at equal intensity, that protecting the load on TMJ. If you miss all the posterior areas, for example, and you chew, all the load goes to the TMJ. That is, if it's tenderness, if you have any tenderness, any tension, will be even worse. But if you have teeth that are optimized up to the first molar, you can have a very good occlusion at this point, and this occlusion on posterior area, very well done, very well remarked, at this point can protect the TMJ to any kind of overloading. And then distribute the load in teeth. All the posterior teeth has to touch the antagonist, especially the buccal lower posteriors, that is the centric cusp, and can be really equal intensity and at the same time. So synchronize at the same level. So I believe that with this kind of treatment, we finalize with the last case in which you have this kind of attrition phenomena. You see that we have an inclination of the incisal edge in one side. The patient wants to do some veneers, but of course, before doing that, they want to understand what kind of problem the patient has. And we define that this is a kind of attrition. So we also tested with the patient to do something to understand. We asked the patient to move from maximum intercuspation to edge-to-edge position. And once she moved, we understood that the muscles were hyperactive, and she felt some problem on the muscle when we have palpated this muscle, the masseters especially, and actually the anterior temporalis, and the patient was having some pain. So I said, where are you touching? Anteriorly for sure, but are you touching on posteriors? I said, yes, I'm touching also on posteriors. So we have interferences. So you have to really let the patient understand what you're doing. Not just an aesthetic treatment, but also you try to have a functionalize your case. So we need to increase the length of central incisor. She came for that, for aesthetic reason. But we already have understood that she had some interferences on posterior area. So we need to put a patient in CR in this case because we are talking about a patient that has the anterior attrition. So that's the reason why we put in place a kind of reorganization approach. We did the direct mock-up. That's a case of a long time ago, 18 years ago. And we have verified the discrepancy between maximum intercuspation and CR position. And we recreate occlusal stability in CR. Doing what? Doing a kind of occlusal adjustment, mostly on posterior area, on old amalgams and old composite restorations. We didn't touch natural teeth. So at this point, with the new anterior guidance, with the new length of the incisors, we had the chance to disclude the posterior teeth during excursive movements, recreating a good anterior guidance. Aesthetically is already better, the patient loved it, the patient want to go ahead with the final work. And we did it. At that time, 18 years ago, we decided to do 6 anterior veneers in the feldspathic porcelain with the refractory dye material. You could understand that we put some little kind of stain inside, color inside on the layering process, plus some little chipping, natural chipping that is made in the mouth, of course, normally. And we try to reproduce in these restorations. 5 years later, the same chipping remained the same, no any difference. She was grinding away her teeth incredibly until the day before the treatment. After the treatment, 5 years later, she doesn't grind anymore, 0. In this case, we should ask ourselves, what about occlusion? It plays a role on bruxism activity or not? Could be possible in this case at least. So the patient is happy about the treatment that we've done. That is just 5 years later. So changes of masticatory movement characteristics after prosthodontic rehabilitation of individuals with extensive tooth wear. So the masticatory cycle converted from a more sharp a ruminating form to one that is sharper. So in the beginning was much larger on the original case. At the end was much sharper. So a prosthodontic occlusal stabilization has been shown to reduce the irregular masticatory movements and the disturbed rhythm seen in a person with malocclusion. So what to say? If you create a perfect occlusion system according to our normal conventional rules, you can improve in 75% of cases a sharper chewing pattern, as you see here. At this point, you have to ask ourselves, modification to dental occlusion may alter oral sensory-motor functions. Restorative treatment aimed to restore sensory-motor function, however, is unclear why some patients fail to adapt. So most of them, they will adapt to the new occlusion, but some of them, they will not adapt. Not everybody. In my case, she was completely adapted because 10 years after, she has still the same kind of little natural chipping. Nothing changed. You can see the time is passing. You see there's some little discoloration on the margins. It's like becoming separate gingival margins, but still very good fit, no problem at all. 10 years later, also lingual part seems to be very good, completely maintained. And now is 18 years later. It's still very good. No more recession on the cervical area, seems to be even better. But you see the anterior guidance, excluding the posterior teeth. So look at the disclusion. Look at the time is passing. Look here and look here. Recessions. Okay? So it's 18 years later. So I believe that is a nice representation of what happened. Sometimes when you try to do a perfect occlusion according to the normal scheme. So I would say, for sure, we know the science, the scientists say to us, occlusion normally doesn't play a role or shouldn't play a role on this kind of bruxism activity. But some cases like the last one I shown, let me say, it's quite understandable that something happened in this case. Maybe in some cases it happened that this kind of patient will be adapted to a new situation, as Eckfeld said. And that is the possibility sometimes to have a good kind of final result, even though you have not really wait maybe for, I don't know, a few months before finalizing the case. Of course, it is safer to do that. Many times our patient doesn't allow us to wait so much, and we need to do some finalization in quite early stage. I believe that if you follow all the occlusion rules that we know, at least in some cases you can have a better final outcome. We know the occlusion doesn't play an important role, at least in the dentistry today. It means that many people believe that it's not so important. It was absolutely a fundamental step long time ago, but now nobody cares. And I believe that is wrong, because at least if you try to dissipate all the load in every teeth, you will really create a better kind of load that is well distributed, not overloading a certain point, not one tooth, not the TMJ, not the muscle. So I believe that the good occlusion, it works very well in any case to really minimize the risk of our fractures, of our restorations, chipping and fractures. I believe that is very important because nobody wants to see patient after finalizing the case in a couple of months complaining about the fracture. So please don't forget, take care about occlusion, even though this is not really directly related to the entity of bracing activity or to the creating of bracing activity. With this, I would like to thank you for staying with me until now, and I will wait you for another lecture. Bye.